is entitled Cardiac Imaging in Amyloidosis, and it's going to be presented by our newest acquisition, which is Dr. Marianna Fontana, who was appointed, who's been working with us as a research fellow for 3 years, and who was appointed as a new consultant and senior lecturer in the Amyloidosis Centre a few weeks ago. Marianna qualified in medicine from the University of Pisa in Italy. She trained in cardiology to consultant level in Italy and then moved to the UK, where she has worked with us and with Professor James Moon at the Heart Hospital on developing new cardiac MRI techniques for amyloidosis. Her research interests include the pathogenesis, diagnosis and treatment of cardiac amyloidosis. And after several years of efforts, we're finally going to be up and running with our new Amyloidosis Centre cardiac MRI machine and a whole new suite and addition to the centre before Christmas this year. And Marianna is going to be delivering that service and doing all sorts of wonderful things. So thank you very much.
So, thank you very much for the presentation, Philip. So in these 20 minutes, I'm going to briefly talk about all the different imaging modalities that we use for cardiac amyloidosis. So cardiac contraction is a very complex phenomenon. It starts with electrical activation of the heart, followed by contraction and relaxation. All these steps are essential for the heart function to be completely normal. This is an example of a normal heart. This is what we call a four-chamber view, because we can see all the four chambers of the heart. This one is the left ventricle, left atrium, right ventricle, right atrium. And this one is an example of a normal heart. What happens with amyloid? As you can see, the main difference is that the heart of the walls becomes significantly thicker and the size of the chamber significantly smaller. So the amyloid can have a kind of disruptive role at the three fundamental steps that happens at each cardiac cycle. So first of all, amyloid deposition at the level of the electrical system can cause delays in the electrical activation. Amyloid at the level of the myocytes can cause decreased contraction, so the pumping function can be decreased. But the most important function that is affected in cardiac amyloidosis is actually the relaxation. The heart becomes significantly stiff and cannot relax properly. So why it is important to assess the cardiac function, amyloid infiltration, and these different steps in the cardiac contraction? So first of all, presence or absence of cardiac involvement and degree of cardiac involvement affect the treatment. There are specific therapeutic chemotherapy regimens that we would advise in cardiac involvement, and the dose may be reduced in patients with advanced cardiac involvement. Secondly, having a picture of all the organs that are involved at the beginning when you come for the first time to the National Med Center is important for disease staging. So how advanced is the disease? How extensive is the amyloid deposition? The third important element is tracking changes over time. As you know, you come to the National Med Center, you would go back to the local hospital, you start treatment. So to understand if actually the treatment is working or not, it's important to have a first very accurate picture at baseline, and then on all the follow-up visits, we repeat all the investigation to see if actually the organ function is improving, is deteriorating, or is stable. So how do we do that? So first of all, we can check the electrical system with a simple ECG. For the contraction and relaxation, we use echocardiogram. To see the amyloid and quantify the amyloid burden, we use cardiac MRI. And to understand how is the interaction between the heart and the rest of the organism, we have very good cardiac biomarkers that are very useful to understand how is this interaction. This is the ECG. How do we do an ECG? Probably most of you are familiar with that. So we need 6 electrodes in the chest, 2 in the legs, 2 in the arms, and the technician with this machine will produce an ECG. So this one is an example of an ECG with a patient with cardiac amyloid. But if you zoom in one of these complexes, these are the waves we look at. But more than the waves, what we look at in patients with cardiac amyloid are the intervals between the different waves. For example, the interval between the P wave and the R wave will give us an indication of how is the velocity of the electrical impulse between the atria and the ventricle. So looking at the interval between the different waves will give us an indication on how much the electrical system has been actually damaged by the amyloid deposition. And why it is important to know that? Because there are several things that we can do at this level. We can, for example, decide to decrease some of the drugs you are taking, like beta blockers, for example, or if the delay in the electrical conduction is severely affected, we can always decide to implant what we call a pacemaker. The second test that we usually do to assess the cardiac involvement is the echocardiogram. These are the technicians, usually to the echo, septa, and beta, and that one was the echo machine. This is a typical example of the pictures we get with echocardiogram. These are again for chamber views, so exactly the same of what you've seen before, but this time upside down. So these are the ventricles and these are the atria. On the left is a patient with no cardiac amyloid, on the right a patient with extensive cardiac amyloid. As you can see, the main difference is the thickness of the muscle itself, significantly thicker on the right rather than the left. And also the size of the chamber is smaller because when the heart muscle becomes thicker, the size of the chamber decreases. We can assess the contraction, measuring the difference between relaxation, maximal relaxation and maximal contraction. But as you probably know, the echocardiogram sometimes takes a long time, and the reason for that is because we take several measurements to assess the function that is mostly impaired in cardiac amyloidosis, that is the relaxation. With all these little waves, we have an idea of how is the relaxation capacity, how stiff is your heart with amyloid deposition. The problem sometimes, not every time, is that the echo is not conclusive for presence or absence of amyloid, because there are several conditions that can increase the wall thickness that are different from amyloid. And one that is very common is hypertension. So if you go to your GP and the heart is very thick, the first thing the GP will think, okay, this is down to hypertension. There's high blood pressure, so the muscle becomes thicker than normal. So this is an example of a patient with high blood pressure and a patient with amyloid. From these pictures, none of us would be able to tell which one has got amyloidosis and which one has got high blood pressure. So there are other tests that we can do to become more specific in this sense. One of the tests that you may have had, but also you may have not had, is a DPD scintigraphy. So this is the machine in the middle, and these are the technicians that do the DPD scintigraphy. So the way the DPD scintigraphy works is that we inject the dye, and 3-4 hours after we take the pictures. This is the machine, as you see, is an open-ended tunnel. And this is the appearance of a normal DPD scintigraphy. So as you see, we can see the bones, but we cannot see the heart. This is an example of the same test in a patient with cardiac amyloid. As you see, we cannot see the bones anymore, but actually there's a lot of cardiac uptake. The problem of this test is that if you take 100 patients with cardiac AL amyloidosis, only in 15% of them, the DPD will be positive. So what we say is there's a high rate of false negative results. So there is cardiac amyloid, but actually with this test we cannot see it. Another test that most of you will have done is the SAP scintigraphy. Again, this is similar, the machine is the same, we inject the dye and we acquire pictures a few hours after or the day after. This is an example of a normal SAP scintigraphy. As you can see, we can see a bit of liver, a bit of heart, but this is just the blood pool. So this is a normal SAP scintigraphy. This is a positive one. So there's lots of black in the liver, in the spleen, in the kidneys, because SAP scintigraphy is an excellent test to see amyloid in the liver, in the spleen, in the kidneys, in the bones, in the adrenal glands, but the biggest problem is that we cannot see cardiac involvement. So what do we do next? So in the past probably 5 years, if there was uncertainty on the cardiac involvement, we used to send patients to the heart hospital, and all the patients had a cardiac MRI there. From December the 6th, we will be fully operational with the new cardiac MRI unit within the National Blood Center. And I would like to show you a little video we've done. The quality of the audio is not great, but I hope that all of you will be able to enjoy the video.
My name is Sarah Anderson. Welcome to the new CMI unit at the National Amyloid Centre. The department at the moment is still as a construction site, but will be fully operational from December the 6th. So I'd like to give you a quick look around now. No one is allowed into the scanner unless they've been safety checked and make sure that they're safe to go in. The reason for that is that it's a very, very powerful magnet. In fact, it's 30,000 times stronger than the Earth's magnetic field. So we need to make sure that everyone is safe to enter into the scan room. So this is the scanner. It's a beautiful, big, spacious room. The magnet is open at both ends, so you don't feel as though you're trapped in any way. Your head, you go on lying on your back with your head first, and then you go into the scanner. Your head is very close to the opening at the other end of the magnet. However, if you should feel claustrophobic, there are other ways that we can try and scan you, like lying on your tummy, if that's better for you. And we do find that even claustrophobic patients, 95% of them or thereabouts, can go through the scan quite comfortably. There's an emergency buzzer with you the whole time, so should you have any problems with the scan itself or you're feeling uncomfortable, you can squeeze the emergency button and we will obviously come straight in to see you. Now let me just show you the control room. In our control room we have a camera on you for the whole time, so you're always monitored. And a nice big clear window so that we can see you and observe that you're okay throughout the scan. And here is a monitor which shows us the other end of the magnet so that we can see you throughout. Okay, so during your scan, I'll be asking you to hold your breath. The instructions are breathe in, breathe out and stop. And you hold your breath normally for about 5 or 6 seconds while I take the picture. Then I'll ask you to breathe normally. The scan on average takes about 45 minutes. However, if you're finding it difficult, then I can modify the scan and make it quicker. We'll do everything we can to accommodate our patients and to make the experience at least a pleasurable one for them. Anyway, that's all for today. Our unit will be open on December the 6th, and I look forward to seeing the first patient then. And I'd like to thank you all very, very much for your very kind donations to this department. Many thanks.
So I hope you enjoyed the video, even though the quality of the audio and there was a bit of delay between the audio and the images, but I thought it was important to show you how the scanner looks like, that even if you are claustrophobic, please do not say no straight away. There are lots of things that we can try, and we can make the scanner shorter, we can change the position, and one of the best things of this scanner is that it's completely radiation free, it doesn't cause any harm, so all of you can basically have the scanner. This is an example of the type of pictures we get with the cardiac MR. As you see, if you compare these pictures with the ones that we get from the echocardiogram, the type of spatial resolution is much higher. we can reconstruct three-dimensional models, and we can have very accurate information on the structure, the functions, and increase in mass in patients with cardiac amyloidosis. Again, normal patient in the left, patient with cardiac amyloid in the right. The difference between the two is striking. However, these pictures don't answer to the main question: what is the reason for this very severe thickening? So these pictures give us much more accurate information than the echocardiogram, but the information is not substantially different. What makes the difference is the administration of the contrast. So after contrast, we get very high specific pictures for amyloid infiltration. So once we do the contrast, the appearance is so typical that we know almost 100%, not in every case, but the diagnostic accuracy is quite high, if the cause of the thickening is amyloid or something else. Again, normal in the left, amyloid in the right. As you see, the difference is striking. So there are definite advantages with cardiac MRI for the diagnosis of cardiac infiltration, but there are problems as well. So first of all, in patients with kidney failure, we cannot give contrast. And there are now new sequences that we can use to avoid giving contrast, but this is still a limitation. Patients with pacemakers, in the majority of cases, cannot have a scan, even though in highly selective case we can still proceed with a scan. And the pictures I've shown you don't give us information on the amount of amyloid. So for example, the 30%, 50%, or 70% of the heart is amyloid. With those kind of pictures, we cannot answer to the question. In the last 5 years, we have been developing this two technique. On the right is an example called T1 mapping. So in green is normal myocardium. All these red flags is amyloid. What we can now do with this technique is measure the amyloid burden, and we can say, for example, 45, 50, 60, or 70% of the heart is amyloid. And why this is important? It's like being on a diet and not having a scale. How can you know if the diet is working or not unless very gross changes happen? And this is exactly the same. We give you a drug, we give you treatment, you come back to us, what happened to the cardiac amyloid? We can now measure it and follow up changes over time. And now actually the technique we developed, and cardiac MRI is one of the one of the most important endpoints used in clinical trials for the drugs that Professor Hawkins has spoken to you before. So in conclusion, with the ECG, we check the electrical system. With the echocardiogram, wall thickness, contraction, and relaxation. With the blood biomarkers, we look at the overall interaction between the heart and the rest of the body. DPD can be informative, but not in all cases. And with CMR, we improve the diagnostic accuracy and we measure the amyloid burden. And we can track changes over time. Thank you very much for the attention.